Hello, this is Dr. Chintamani Gudbole. In today's video, we shall be discussing the 4 strategies that we can use to avoid a permanent colostomy or a permanent stoma in rectal cancer. As I have discussed in my earlier videos, rectum is the last part of the large intestine. The last 5 centimeters of the rectum is surrounded by 2 rings of muscles called the internal and the external sphincter. These sphincter muscles are responsible for controlling the flow of stools. Cancers of the rectum, especially when they involve the last 5 centimeters, can often involve these sphincter muscles. Because of this reason, whenever we have to do surgery for such type of cancers, we may land up giving the patient a permanent stoma or a permanent colostomy. However, in this video I would like to discuss 4 strategies by which we can avoid a stoma in some of these patients. Strategy number 1 is doing a staging MRI. A MRI scan can accurately tell us the local stage of the tumor, which means it gives us correct information about the location of the tumor, the depth of penetration, and whether the tumor is involving the surrounding structures, especially these sphincter muscles as discussed before. This information is mandatory in deciding what type of surgery to perform for rectal cancer. Doing an MRI is important for identifying patients in whom a permanent colostomy or a permanent stoma can be avoided following surgery for rectal cancer. Strategy number 2 is pre-operative radiotherapy. This means radiation therapy that is given before or prior to surgery. This strategy is now the current standard of care in most patients with rectal cancer. Radiation therapy given prior to surgery not only results in shrinkage or downstaging of the tumor, it also reduces the chances of recurrence of the tumor within the pelvis after surgery. With radiation and especially with shrinkage of the tumor, it is often possible to preserve the sphincter or the sphincter complex, hence enabling to avoid a permanent stoma or a colostomy after surgery. Strategy number 3 is advanced surgical techniques which include robotic surgery and intersphincteric resection. Robotic surgery enables the surgeon to get magnified views of the field of surgery within the pelvis. It makes sure that the surgeon can accurately dissect or separate the rectum from the surrounding structures, including the sphincter muscles. I have discussed this in one of my earlier videos, that robotic surgery nowadays is the standard of care or the ideal modality when we are doing surgery for rectal cancer. Especially in patients where we are keen to preserve the sphincters and we want to avoid a stoma, robotic surgery has great advantages. Intersphincteric resection is a surgical technique that we use to separate the rectum accurately from the external sphincter, especially when the tumor is involving the lower part of the rectum. This technique, when used in a selected group of patients, can help us avoid a stoma and preserve the sphincter complex in rectal cancer even when the tumor is very low. Strategy number 4 is choosing the right specialist. Rectal cancer is a complex disease and often needs multimodality treatment, which includes advanced surgery, chemotherapy, and radiation therapy. It is therefore important to choose a surgical specialist who is well trained and has experience in treating this complex disease. Although as a patient, this may not be very easy, a good marker of this would be the surgeon's training. The surgeon should be a super specialist having the qualifications of DNB or MCH in either surgical gastroenterology or surgical oncology. Please read the surgeon's profile and find out whether the surgeon has worked in high volume cancer centers and indeed whether he or she has experience in performing surgery for rectal cancer. Despite all the medical and surgical advances, a permanent stoma is sometimes the only option in patients with rectal cancer. However, with the accurate use of these 4 strategies, which include preoperative staging MRI, radiotherapy, advanced surgical techniques, and choosing the right specialist, the whole idea is to identify a subgroup or a subset of patients in whom a permanent colostomy may be avoided despite having the full treatment for the rectal cancer. Thank you for watching this video. If you like the content, please like and subscribe. Thank you.